In this disease, patient is a heavy smoker. Later, a growth like this happens in his lungs. What is this? It is lung malignancy, lung cancer, bronchogenic carcinoma. Let us see the primary lung malignancies. Primary lung malignancies, we have non-small cell lung cancer, non-small cell lung cancer, written as NSCLC, and there is small cell lung cancer, small cell lung cancer, written as SCLC. In non-small cell lung cancer, the various types, we have adenocarcinoma, squamous cell carcinoma, adenocarcinoma, squamous cell carcinoma, large cell carcinoma, large cell carcinoma. In small cell carcinoma, we have only one variant. Small cell tumor, are also called as Wort cell tumor. Out of this adenocarcinoma is the most common type worldwide. Adenocarcinoma is most common type. The various types of lung malignancies: adenocarcinoma, squamous cell carcinoma, large cell, small cell. For your exam, they will ask you the differentiating features of adenocarcinoma, squamous cell carcinoma, small cell carcinoma. Because large cell is not routinely seen in clinical practice, they are not going to ask you. You should know the differentiating features of these three. Make a table. I am going to discuss these three together: adeno, squamous and small. Starting with adenocarcinoma, this tumor is peripherally located. Adenocarcinoma, it is peripherally located, peripheral location, and this is most common type in females, non-smokers, females, non-smokers and young males, females, non-smokers and young males. And this adenocarcinoma is most common histology in asbestos. We have discussed that asbestos will cause lung cancer. In that, most common histology is adenocarcinoma. Most common histology in asbestos related lung cancer, and this is the lung cancer with highest incidence of clubbing. It can cause most severe form of clubbing called as hypertrophic osteoarthropathy, hypertrophic osteoarthropathy. Then these tumor cells can produce few substances and can release in and can result in few manifestations. These manifestations due to products of tumor cells are called as paraneoplastic syndromes. Adenocarcinoma can cause hematological paraneoplastic syndromes, and most important of those is migratory venous thrombophlebitis, that is nothing but Troche syndrome. The other name is Troche syndrome. These are the important features of adenocarcinoma. Next, coming to squamous cell carcinoma. Whenever I discuss about squamous cell carcinoma, you should be knowing 4 C's. What are these 4 C's? First C, it is centrally located. it is associated with cigarette smoking. There can be cavity formation associated with a paraneoplastic syndrome with respect to calcium called as hypercalcemia. Now, why there will be hypercalcemia? Because the tumor cells can secrete excess parathermone related peptide. There will be secretion of excess parathermone related peptide. And point to be noted here, this can be life threatening. The patients with squamous cell carcinoma can present with severe hypercalcemia that can result as a life threatening metabolic abnormality. What will be the features of severe hypercalcemia? These patients can have altered sensorium, polyuria, abdominal pain. Now, why will hypercalcemia cause these manifestations? Whenever there is excess calcium in your body, when there is excess calcium around the nerves, your nerves cannot fire properly, your neurons cannot function properly, there will be altered sensorium. When there is excess calcium, it will not allow antidiuretic hormone to function on your kidney. Because antidiuretic hormone is not functioning, water will not be reabsorbed, it will be lost in the urine. That results in polyuria. This phenomena is called as nephrogenic diabetes insipidus. When there is excess calcium, the same old story, renal stones, biliary stones, all this will cause abdominal pain. Coming to small cell carcinoma. This is also centrally located. And this has strongest association with smoking. No doubt both squamous and small are associated with smoking. But if they ask you strongest association, your answer should be small cell carcinoma. This tumor is both chemo and radiosensitive. Whenever I find a tumor both chemo and radiosensitive, what do I expect in treatment? I feel I can easily treat it. But the problem is it will initially respond. Later there will be rapid recurrence and increased metastasis. Because of rapid recurrence and increased metastasis, there will be very poor prognosis. Rapid recurrence, increased metastasis, there will be very poor prognosis. And this is the tumor that is associated with SVC obstruction. What is SVC obstruction? Superior vena cava obstruction. And clubbing is rare here. And this small cell carcinoma can cause so many paraneoplastic syndromes. It is responsible for so many paraneoplastic syndromes. Now, why clubbing is rare here? Whenever I say clubbing, one of the important disease that should come into your mind is lung cancer. Now, this small cell carcinoma is such a rapidly progressing lung cancer. Why clubbing is rare? The reason is, before clubbing can happen, patient will not be there. That's why it is very rare. See, the life expectancy of a patient with small cell carcinoma is only few months. In that few months, clubbing may not be manifested, because before clubbing can manifest, patient is not surviving. So that might be the reason why clubbing might be rare. It is associated with many paraneoplastic syndromes. Let us see few paraneoplastic syndromes. It can cause hyponatremia. This hyponatremia is due to syndrome of inappropriate ADH. It can cause hypokalemia. This hypokalemia is due to production of ectopic ACTH by the tumor cells. There can be hypocalcemia. This is due to production of calcitonin by tumor cells. Production of calcitonin by tumor cells. Apart from this, there can be a neurological manifestation called as Lambert-Eaton syndrome. This is a neurological disorder. You can learn this in your CNS, neurological disorder. A neurological disorder called as Lambert-Eaton syndrome can happen with small cell lung cancer. Now, how to remember this? If you observe here, there is hyponatremia, hypokalemia, hypocalcemia. What is meant by hypo? Hypo means less. What is meant by small? Small is also less. So, majority of hypos are caused by small cell carcinoma, whereas hypercalcemia is a life-threatening complication of squamous cell carcinoma. This is a very important table. I have concised all the important questions in this single table. From this single table, they can ask you multiple questions. In the question, if you see Troche syndrome, clubbing, your answer should be adeno. Hypercalcemia, cavity, your answer should be squamous. More metastasis, poor prognosis, SVC obstruction, multiple paraneoplastic syndromes, your answer should be small cell carcinoma. If you go through this table, you can answer so many questions, students. Now, let us see the clinical manifestations of lung cancer. Whenever a patient develops lung cancer, what will be the important clinical manifestations? Write down clinical manifestations. Clinical manifestations. Now, let us say this is the lung. Let us say this is the lung. Let this be the bronchi. Initially, suppose a small tumor is developing like this. It can cause irritation to the surrounding pulmonary mucosa. There can be irritation to surrounding pulmonary mucosa. Because of this irritation to surrounding pulmonary mucosa, patient will develop cough. Now, this tumor gradually can infiltrate a blood vessel. Whenever blood vessel infiltration of blood vessel, this patient can develop hemoptysis. This tumor can grow in size and occlude the bronchus. Occlusion of bronchus results in bronchial obstruction that causes collapse. Bronchial obstruction, collapse. Now, this collapse, the part of lung is not taking part in gaseous exchange. Patient can develop shortness of breath. Patient can develop shortness of breath. Now, this tumor can migrate onto the pleural surface. It is migrating onto the pleural surface. Once it migrates onto the pleural surface, there will be pleuritis. Because of pleuritis, patient will develop chest pain. As time progresses, there can be development of pleural fluid. This phenomena is called as pleural effusion. Because of pleural effusion, again patient can have shortness of breath. Now, this tumor created lot of problem within the lung. Now, it is migrating out onto the skin and intercostal nerves. involvement of skin and intercostal nerves, involvement of skin and intercostal nerves, this patient will develop chest pain. This patient will develop chest pain. Now this tumor is migrating to the surrounding compartment. What is the surrounding compartment? Mediastinum. In the mediastinum, it will come across the pericardium. Involvement of pericardium. Involvement of pericardium will result in pericarditis and pericardial effusion. There will be pericarditis and pericardial effusion. This tumor can involve the esophagus. Involvement of esophagus. This patient will develop dysphagia. When esophagus is involved, there can be dysphagia. Now this tumor can involve a nerve which will turn around like this. What is the nerve turning around like this? It is recurrent laryngeal nerve. Involvement of recurrent laryngeal nerve. Involvement of recurrent laryngeal nerve will result in hoarseness of voice. Will result in hoarseness of voice. Involvement of recurrent laryngeal nerve will be responsible for hoarseness of voice. Now this tumor can involve a very big blood vessel in the neck. It can involve a very big blood vessel in the neck called as superior vena cava. Involvement of superior vena cava, patient will develop superior vena caval obstruction. Superior vena caval obstruction, also called as SVC obstruction. What will be the features of SVC obstruction? There will be neck swelling and dilated veins over chest wall. Neck swelling, dilated veins over chest wall. Now why this happens? Because your superior vena cava is a major vein. Veins from the neck and your chest wall will drain into the superior vena cava. Whenever it is obstructed, there can be backflow of blood resulting in neck swelling, dilated veins over the chest wall. In the neck, there is a beautiful structure containing so many sympathetic nerves. What is this structure? It is stellate ganglion. Involvement of stellate ganglion. Involvement of stellate ganglion. Patient can develop Horner's syndrome. Patient can develop Horner's syndrome. Now what are the components of Horner's syndrome? Now tell me, this stellate ganglion, is it a sympathetic ganglion or a parasympathetic ganglion? It is a sympathetic ganglion. It is a sympathetic ganglion. Its involvement will cause anhydrosis, meiosis, ptosis, loss of ciliospinal reflex, loss of ciliospinal reflex, anophthalmos, anophthalmos. It is a sympathetic ganglion that is getting involved. Because of the involvement of sympathetic ganglion, you can get anhydrosis, meiosis, ptosis, loss of ciliospinal reflex, anophthalmos. The features of Horner syndrome you can remember with a simple mnemonic called as sample. It is the sympathetic ganglion getting involved, and the manifestations: anhydrosis, meiosis, ptosis, loss of ciliospinal reflex, anophthalmos. Now this tumor is going for distant metastasis. Distant metastasis. Distant metastasis, it can involve adrenals, it can involve brain. So distant metastasis, adrenals, brain, liver, bones, adrenal, brain, liver, bones can be involved. So these are the important manifestations of lung cancer. So whenever a lung cancer is there, patient can have these manifestations. Whenever there is a lung cancer, patient can have these manifestations. Coming to investigations. How do you investigate and finally conclude it is malignancy? Investigations. We'll start with basic investigations. When there is an available sample, you should send it for cytology. Sputum for malignant cells, pleural fluid for malignant cells, and within the chest X-ray, depending upon extent of the disease. Initially, it can be a small lesion called as solitary pulmonary nodule. It can extend into collapse. It can result pleural effusion. Because of mediastinal extent, it can cause mediastinal lymph node enlargement. And in majority of cases, I am going to take a CT chest. The reason is CT chest will help me to know the precise anatomical location, where exactly the tumor is present, precise anatomical location. Now if they ask me what is the gold standard test when tumor is the rumor, cancer is your answer, then tissue becomes the issue. Get the biopsy for confirmation. Biopsy, either CT guided biopsy or we can go through bronchoscopic biopsy, thoracoscopic biopsy. You get some tissue, your pathologist, if they give it as malignancy, that is gold standard. Then after diagnosis, next step is staging. For staging, we go for a PET scan. PET scan is for staging. So this PET scan is a metabolic scan. Now there is already presence of tumor in his body. Now you find hypermetabolic areas, for example in bone, liver. What does all this indicate? This all indicates metastasis. This is a simplified algorithm. This is a simplified algorithm for investigating lung cancer. Then coming to the treatment part. Treatment of lung cancer. Whenever you are treating lung cancer, first thing what you should know is the histology. Are you dealing with non-small cell lung cancer or the small cell lung cancer? Are you dealing with non-small cell lung cancer or small cell lung cancer? If it is small cell lung cancer, by the time patient reaches you, it would have been an extensive disease. When the disease is very extensive, there is no point in doing surgery because you cannot go and cut each and every part of the body. What you do here is chemoradiation. Radiotherapy is taken care of by my radiotherapy friend. Chemotherapy I am going to advise. So what do you give as chemotherapy here? We can give combination of cisplatin plus etoposide. Cisplatin plus etoposide. Now if it is non-small cell lung cancer, what you should do is you should see whether it is a localized tumor that is resectable or more extensive tumor unresectable. For this, staging might be necessary. Resectable tumors generally belong to stage 1 to stage 3A. Unresectable tumors usually belong to stage 3B to stage 4. For undergraduate level, lung staging is never being asked, and it is also very complicated. You need to know the mediastinal anatomy, you need to know the lung anatomy. So tumor, nodal stations and metastasis. But for few students who feel that we need to learn everything, after this video there will be lung staging uploaded as a supplementary video. So I have done it for my postgraduates, but I am uploading it here for those people who wish to know everything. So you can see the lung staging video, but generally for undergraduate level you should know up to this, which is resectable, which is unresectable. Now if it is a resectable tumor, you have to resect it. Primary therapy will be surgery. If it is unresectable, now what is the most important principle while doing surgery for any malignancy? You should make sure you are removing the tumor completely without any remnants. Now in stage 3B what happens is, tumor might be encroaching onto the mediastinum, onto the trachea, onto the diaphragm. So you cannot completely resect the tumor. Stage 4, already distant metastasis. Because it is already spread, there is no point in removing the primary. In unresectable tumor, the only option will be chemoradiation. Now what will be the chemo regimens? It again depends upon the histology. What to give in squamous cell carcinoma, what should be given in adenocarcinoma. For squamous cell carcinoma, we generally prescribe cisplatin plus gemcitabine, cisplatin plus gemcitabine. In few areas we also give paclitaxel. Adenocarcinoma, it is cisplatin plus pemetrexed, alternative to pemetrexed, bevacizumab. For adenocarcinoma, there is a special treatment called as targeted therapy. We know that these tumor cells proliferate because of abnormal activation of oncogenes. These tumor cells can proliferate because of abnormal activation of oncogenes. Now I give treatment to inhibit those oncogenes. There is EGFR inhibitors, and also we have ALK inhibitors, EGFR inhibitors, then there is also ALK inhibitors. EGFR inhibitors, we have erlotinib, zefitinib. ALK inhibitors, there is crizotinib. ALK inhibitors, there is crizotinib. This is the simplified algorithm for management of lung cancer. Whenever you are thinking to treat a lung cancer, what is the first thing that you should know, students? You should know, are you treating non-small cell or small cell? If it is non-small cell, mostly it is extensive chemoradiation. If it is small cell, it is chemoradiation, because by the time patient reaches you, it will be extensive. If it is non-small cell, resectable, surgery is the primary therapy. Unresectable, we go for chemoradiation. What to give in squamous, what to give in adeno. Again there is in adenocarcinoma targeted therapy, EGFR inhibitors, ALK inhibitors. Apart from this, there is another treatment for lung cancer called as immunotherapy. So this immunotherapy, we have anti-PD-1 antibodies, nivolumab, pembrolizumab, anti-PD-1 antibodies, nivolumab, pembrolizumab. Now what is the principle behind this? When I started the class, I told you, whenever there is any pathology happening in your body will try to fight against that pathology. Now tumor is such an abnormal phenomena happening. Why your body's immunity is not fighting against it? This was the question in minds of two scientists, Allison and Honjo. The question is, why body's immunity is not fighting against tumor cells? Why body's immunity is not fighting against tumor cells? Now let us see the mechanism, what exactly is happening. Consider this is your immune cell called as T cell. On the surface of T cell there will be some break proteins. The name of this break protein is PD1. PD1 means programmed cell death. PD1 means programmed cell death. Now what is the function of brake in your car? What is the function of brake in your car? Whenever it is activated, whenever the brake is activated, your car slows down. In the same way, whenever these brake proteins are activated, your immune cells function will slow down. Now suppose let this be the tumor cell. These tumor cells are very intelligent. They make friendship with these brake proteins. They bind with these brake proteins, or they produce substances which bind with this brake protein. Tumor cells can bind with brake protein, and activates brake mechanism. Once the brake mechanism is activated, there will be decreased T cell function. This is how tumor cells are escaping my body's immunity. They bind with brake proteins, they activate the brake mechanism, they reduce the T cell function. Then what is the solution? Solution is anti-PD1 antibodies. These anti-PD1 antibodies also bind with brake proteins. They bind with brake protein but deactivates the brake mechanism and deactivates. It is going to break that brake and deactivates brake mechanism. Once brake is removed from your car, when it starts, it will not stop. So what will happen to T cell function? It will increase, and these T cells can cause tumor destruction. In simple words, immunotherapy is nothing but making your immune cells destroy the cancer cells. Now we are having for lung cancer nivolumab, pembrolizumab. Still it is in the beginning stage, this immunotherapy technology. Maybe after few years all the chemotherapy will be replaced by immunotherapy for cancer. So this was this theory and this concept and these drugs were only because of research of two scientists, Allison and Honjo. For their work they were given Nobel Prize in Medicine in the year 2018. So this is regarding immunotherapy. You should know anti-PD1 antibodies bind with the brake protein. They are going to remove the brake, deactivate the brake, increase T cell function. All this can cause tumor destruction. Let us see some cases, students. Case number 27. There was a 47-year-old restaurant owner, smoker. He presents with productive cough, blood streaked sputum. His physical examination normal, CBC was normal, sodium low, potassium chloride okay, kidney liver function test normal. The chest X-ray is given. Chest X-ray you can see a central mass or a central lesion. You can see a central lesion, and bronchoscopy within the bronchus. You can see a tumor, and you are taking a biopsy. Bronchoscopy biopsy was positive for tumor cells. Which of the following is most likely lung carcinoma causing this clinical presentation? Very simple. Patient is smoker. There is centrally located tumor, centrally located lesion, central location, and hyponatremia. Normal sodium 135 to 145, it is 124, significant hyponatremia. All this put together, it should be only a single answer. What is that? Small cell carcinoma. Small cell carcinoma. Why it is not squamous? Squamous can also be seen in smokers, centrally located. But in squamous, generally, what will you see in squamous, students? It is hypercalcemia. Squamous is generally hypercalcemia associated. Now, this patient is having these manifestations. No doubt this manifestation is clubbing. Now, what is this manifestation? Initially the inflammation was here, then here. Now it has progressed to here. There is migration of this inflammation. This is migratory venous thrombophlebitis, also called as Troche syndrome. When you see these two in combination, Troche syndrome and clubbing, what should be your answer? It is adenocarcinoma. Your answer should be adenocarcinoma. Case number 28. Answer is adenocarcinoma, clubbing plus Troche syndrome. Now first tell me the case number 30 answer. What do you see in case number 30, students? What do you see here? Yes, you can see there is neck swelling. You can see there is neck swelling, dilated veins over the chest wall. Neck swelling and dilated veins. So this everything is the neck swelling and dilated veins over the chest wall. Neck swelling and dilated veins. So this is the neck swelling. This is the dilated veins over the chest wall. What should be your diagnosis? Your diagnosis should be SVC obstruction. And what is the tumor responsible for this SVC obstruction? See, neck swelling, dilated veins, it is small cell carcinoma. So this is an SVC obstruction. The answer for this is SVC obstruction, and the tumor is small cell carcinoma. Case number 30, it is SVC obstruction, small cell carcinoma. Then question number 29. What do you see here, students? When compared to this side, there is narrowing of this aperture. This is ptosis, and patient was having a lung cancer. What is this called as? This is Horner's syndrome. So when will Horner's syndrome generally happen? When there is involvement of stellate ganglion. So write down, consider this is the lung, and here you will have stellate ganglion. Usually tumors of lung apex, can involve the stellate ganglion. What are tumors of lung apex called as? Pancoast tumors. Tumors of lung apex are called as a Pancoast tumors. And most common histology will be squamous cell carcinoma followed by adenocarcinoma. Most common histology will be squamous cell carcinoma followed by adenocarcinoma. Whenever there is a Pancoast tumor, what all manifestations a Pancoast tumor can cause? So this tumor can extend upwards and involve the stellate ganglion. It can cause Horner's syndrome. And this tumor can extend outwards and damage the first two ribs. It can cause destruction of first two ribs. It can cause destruction of first two ribs, and this tumor can extend posteriorly. This tumor can extend posteriorly onto C8, T1, T2. There will be involvement of C8, T1, T2, resulting in involvement of C8, T1, T2, resulting in pain and weakness along ulnar distribution, resulting in initially pain and later weakness in ulnar distribution. Now the tumor, it can extend posteriorly involving the C8, T1, T2 nerve roots, resulting in pain and weakness in ulnar distribution. All these manifestations, what a Pancoast tumor can result in, is put together called as Pancoast syndrome. The manifestations that a Pancoast tumor can cause is put together and called as, all these manifestations put together is called as Pancoast syndrome. Pancoast tumor means presence of tumor in the lung apex. Pancoast syndrome is the composite of all manifestations of Pancoast tumor. Whenever I discuss any lung disease, for imaging purposes, I never write MRI chest. I generally write CT chest. What is the reason? MRI chest, the lung contains air. Air will not give proper signals in MRI. But there is one indication where I should write MRI chest. That indication is Pancoast tumor. The reason is Pancoast tumor can involve the nerve roots. MRI chest will give excellent visualization of these nerve roots. So that's why this was asked previously. MRI chest is helpful in Pancoast tumor to assess the nerve root involvement. Previously asked question, which of the following is an indication for MRI chest? The answer was Pancoast tumor. Why? To assess the nerve involvement, because Pancoast tumor can involve C8, T1, T2. Pancoast tumor can involve C8, T1, T2. So this is regarding lung malignancy. So we have discussed the differentiating features of adeno, squamous, small, the clinical manifestations, investigations, treatment and various case scenarios. Then coming to tuberculosis, recently there is a 2021 update. So this 2021 update, myself and pharma faculty for about 3 hours we have discussed as an integrated session under DAMS integrated MCQ rounds. You can go through it, because this will give you the whole information regarding the clinical manifestation, the new treatment guidelines, along with that the drug dosings and also most importantly the drug side effects. It will tell you the drug side effects, when to use what will be the drug side effects. So all of you, after completion of this video lecture, once have a look at DAMS integrated MCQ rounds. So where we discussed, myself and pharma faculty have discussed tuberculosis 2021 update. It includes everything, the clinical manifestations of TB, the new guidelines, the drug information, everything that is required for your exam students.